Good afternoon, ladies and gentlemen. My name is Felipe Seligman. I'm co-founder of Jata, and I'll be the co-moderator of this amazing event together with Mr. Carlos Gouvêa, Executive President of the Cbdl, or in Portuguese, Câmara Brasileira de Diagnóstico Laboratorial. Jota is a journalism and technology company from Brazil that produces information, data, and analysis about legal, regulatory, and institutional matters. One of our main verticals, Jota Pro Sawji, is focused on health-related issues. We follow on a daily basis the regulatory agencies like Anvisa and NNS, besides all the superior courts and the National Congress. That's the reason why we are so proud of host this event, organized by so many great institutions. Today, we'll talk about the role of diagnostic in the COVID-19 pandemic response. Here, I need to thank Mr. Carlos Gouvêa that was very generous to invite Jota to be part of this event. And I would like also to thank Dr. Mariângela Simão, Assistant Director General, Access to Medicine and Health Products of the World Health Organization, Dr. Rosanna, Professor and Chair of Diagnostic Research and Diagnostic Research Director of International Diagnostic Center from the London School of Hygiene and Tropical Medicine, and Mr. Álvaro Pulchinelli, Scientific Director from the Sociedade, Brasileira de Patologia, Clínica e Medicina, Laboratorial. So before we start our presentations, I will explain a little bit how the webinar will work. We will have three amazing presentations. Dr. Simão will talk about WHO tools for improving access to effective solutions against COVID-19 pandemic. Dr. Pilling will address how to support patients' management and public health measures in the fight against COVID-19. And Alvaro and Carlos will talk about the innovative and collaborative approach by the Brazilian civil society and regulatory authorities to promote. Before passing the word to Dr. Simão, I'd like first to pass the floor to Carlos so he can thank all the institutions that are part of this event and also introduce a little bit more about the event. Thank you so much, Carlos, for being here. The floor is yours.
Thanks a lot, Felipe. It's a great pleasure to have you commanding this webinar. Thanks a lot. It's really remarkable. I would like to thank Dr. Mariângela Simão, Rosanna Pilling, and Álvaro Pulchinelli for attending our invitation to share a little bit of their experiences in this very challenging moment. We all know how difficult it has been for all the different governments, citizens, companies everywhere. Someone is facing a new challenge with the pandemic we are now living. And for that, it's really important to show a little bit of hope. So what are the tools that WHO is planning to have? What is the work behind that? Rosanna, with her global view, also is going to share a lot of the different organizations and scientific people involved in this important commitment to really fight against the COVID. And Alvaro will bring a little bit of what we have been doing in Brazil. So it's a really complete panel that would only be possible through partnership, collaboration with all the different stakeholders. And here I really want to thank all the medical societies. So Sociedade Brasileira de Análises Clínicas, Sociedade Brasileira de Patologia, Clínica e Medicina Laboratorial, Abramed, Associação Brasileira de Medicina Diagnóstica, a própria Cbdl, with all the members that have been really working very hard in order to bring access, and access that would not be possible without the full support and continuous effort by Anvisa. All the different managers and officers from Anvisa have been working very hard in making this possible. Not only diagnostics, medical devices, services, inspections, and the board of directors. Everyone has been involved in a different moment, but always with a common goal of improving the access and quality of products. So with that in mind, I really would like to thank Anvisa, Ministry of Health, and ANS, which is now considering a new momentum for the incorporation of serological tests, which is really very important for the private sector. And so, considering all this, it's a work in progress. I would like to start and invite Dr. Mariângela, to whom we really thank a lot because of all her movements in her logistics, to be able to share a little bit of her experience, which we really appreciate. And Felipe, please, you can start. And just in Portuguese quickly, toda essa apresentação e a discussão, ela a princípio vai ser em inglês, mas nós teremos depois uma gravação em português nas próximas semanas. Então, o material, que é um material riquíssimo, como vocês vão ver, ele vai poder ser acessado mais vezes, tanto pelo Jota, quanto pela Cbdl e pelo portal do programa de avaliação. Thanks a lot, and let's have a good webinar. Success.
Perfect. I'll pass now the word for Dr. Mariângela Simão, and I will share her presentation and command it. So please, whenever you need to pass, just let me know that I'll do it. Let me see if it works. Okay, is it working?
It works. You need to put on the presentation mode.
Yes.
Let me start by thanking the organizers for the opportunity to be here today, and thank you very much, Carlos and Felipe. And also let me say that it's very welcome news about the INS in Brazil being concerned and contributing to the COVID response. It's very welcome news that the private sector also comes in with very concrete inputs in like the one on the serologic test. First of all, let me say that I'm not a diagnostic specialist, and what I'll bring to you today is an overview of the different work streams that are happening globally related to COVID tools. And this slide set, which will be made available, it's also a collection of slides from different partners who are working internationally, the global health partners who are working internationally to make these tools available in the fastest time and possible, the research and development and the equitable access to them. Can I have the next slide, please? The slide is just to show that the WHO hosts the coronavirus COVID dashboard. You just Google it and you'll find up-to-date information about different countries and the latest number of cases, deaths, and everything else. So you see here the hot spots in the world, the countries where the epidemic is at the community transmission still not under control, the dark ones. Next one, please. This is just to show you can find this information. You can click on in each country and find specific information. And let me say that this pandemic has brought some good things. And one of them is that there is a much more coordinated approach globally to research and development of what we are calling the acceleration, the Access to COVID Tools Accelerator. This is Act A, where we have a conjunction of international organizations that were working together very intensively to bring products that will be useful in combating this pandemic to the market, to people in countries in the fastest way possible. So this is just an outline of the ACT Accelerator, where we have 4 pillars. One is the vaccines pillar, the therapeutics pillar, diagnostic pillar, and we also have a health systems connector. You'll see this, I'm not going to go into details, but each of these pillars is co-led by a couple of international organizations, while WHO does the coordination and support and has all the cross-cutting functions and norms and standards, the regulation, and so on. Next, please. So the first I'm going to go quickly through the vaccines pillar. because what we call COVAX, right? And this slide actually originates from the Vaccines Alliance, the Gavi, because we have WHO's Director General has been saying, and he's absolutely right, in this time when you have so many news about countries closing deals, bilateral deals with different companies and so on. The reality is that this pandemic is very pervasive, and we have cases registered in 184 countries right now. So no one is safe until everyone is safe, right? And this is absolutely important to think that we need global solutions and not unilateral or individual countries solutions, right? So this is the approach that we have right now. Next, please. On the vaccines, most of the interviews I've been giving in the past weeks have been on the vaccines, because there's so much hope. I think there's a lot of belief on vaccines, on confidence on vaccines, even though the vaccine hesitancy has been rising across the world, but there's still a lot of hope that we'll get out of this pandemic with a vaccine. And WHO is saying it's not only, it's going to be a conjunction of elements. We need proper diagnostics. We need timely diagnostics. We need all the tests and contact tracing and the follow-up and everything. We do need 1 or 2 good vaccines, and we do need therapeutics that will decrease mortality because of this coronavirus. On the vaccine side, we have 4 technologies. We have more than 200 vaccines, around 200 vaccines, candidate vaccines being developed around the world. 25 are already in clinical trials, and 3 or 4 are on phase 3 trials. And people have been asking, which are the most promising? There's nothing, there are ones that are more advanced and the ones that are still in the initial phases, right? We cannot at this stage say which one is going to be successful, because we have different platforms. We have a protein platform, we have a DNA RNA, which is a very new platform, the messenger RNA, nucleic acid. We have the viral vectors, we have the usual that we know, the inactivated, attenuated vaccines. So some of these platforms are new ones, and the world has never had a vaccine with this platform before. So there are regulatory challenges as well as the usual research and development challenges. Next, please. So we have learned some things from the past pandemic, and one of them is that the past pandemic, the 2009 H1N1, you will remember that one. Whoever is watching this panel was alive then and was already probably a health professional by then. The reality was in 2009 that rich countries got the vaccine much earlier than developing countries. And at the end of the day, what happened when the developing countries got access to the vaccine, the pandemic had gone away. We don't think this pandemic will go away like H1N1. Hopefully it will, but it doesn't look like. This coronavirus is being very resilient, and it's a new coronavirus. So we're still learning about its immunogenicity, about so many things, about the long-term effects and about asymptomatic transmission. There's still too many things, too many unknowns about the virus, which will affect. We don't know the immunology quite well. When you are, as diagnostics experts, you know the challenges on that. So what WHO is working and presenting to member states is an allocation framework and mechanism, because it's envisaged that when we do have a vaccine, we will have a vaccine with cautious optimism, because we have so much investment on it, and it's like I said, almost 200 candidates, and there's a lot of interest in a vaccine, a lot of financial inputs into a vaccine. But once we do have a vaccine, it won't be in the first year. We know for sure that it won't be enough to vaccinate everybody who wants to be vaccinated. So WHO is proposing an allocation framework, working with Gavi and CEPI. Gavi is the Vaccine Alliance, and CEPI is the Epidemic Preparedness Initiative with vaccines. So we are working under the assumption that all countries should receive vaccines at the same time, and that we would aim at reducing mortality and protecting health systems. Those are the goals. And we are preparing for an initial phase, what we're calling phase 1, where countries would receive doses proportionally to their population, up to 20% of their population. Countries that join a global mechanism, I'll explain a little bit later. So the idea is that we have health and social care workers prioritized and high-risk adults, which include people over 65 and people with comorbidities. This is around 2 billion doses already. Just this 20%, if we would cover the entire world, would be around 20%. This is a negotiation that's working, that's being managed right now with member states, with all countries, on what would constitute an allocation framework and mechanism. Next, please. So we will need to prioritize population. And then there are the opportunities, because you need to address the uncertainties. We have so many candidates. And if you're going to invest in 1 or 2 or 3 or 4 or 5, depending on you, and what about if your candidates, the ones you're investing in, are not the ones that will be successful? So we're in the process of organizing a global access facility that will be managed by Gavi, which would offer a fair access and allocation across countries, opportunity across countries, through a risk pooling mechanism. Countries have expressed interest so far among upper middle income countries and high income countries. 77 have expressed interest, including Brazil, in joining the facility, and plus the 90 countries that are usually benefiting from Gavi support. So we potentially have around 160, 170 countries aligning in a global mechanism that will give everyone more chances to access a safe and efficacious vaccine when it becomes available. Next. And then the second pillar that I'm going to talk about is the therapeutics pillar. There are around 1,700 trials ongoing globally, and this has become, and this is all the information when you receive the slides. You can, each of these are links. You can go directly to the living map on ongoing research, on studies per country, show study design, severity, and so on. Live synthesis of the study results, what we have so far. So this is what you can find information as you need. Because the other pandemic we have at the same time that we are fighting coronavirus is the misinformation pandemic. And it's super important that there is that population, the people know where to find correct information about whether a drug is being effective or not. Next slide, please. This is just to tell you that this therapeutics partnership has these 4 work streams: the rapid evidence assessment of candidates, market preparedness, adequate deployment in all countries, cost and financing. And this partnership is led by the Wellcome Trust and Unitate. Next, please. And here we get to, I'm sorry, it's a very busy slide, but just pay attention to the axis, in the parallel structure. It's the ability to deliver at scale, and these are some of the drugs that are being assessed. Like I said, the 1,700 trials, around 200 different drugs. So you have and measured against health impact. So you have drugs that are like what it was already a lot on the news, remdesivir, which is a drug by a US company, Gilead, that did some voluntary licensing to other countries. You see that the health impact is medium low, right, of remdesivir, because it doesn't, so far has not proved that it impacts on mortality, just reduces hospitalization. Let's see if other studies come up. But at the same time, you have hyperimmunoglobulin, which showing high impact or plasma from convalescent patients, but then the ability to deliver at scale, it's very low. And on the right-hand side, you have the other drugs that are being studied. You know, dexamethasone is an excellent example because it's a small molecule. It has been in the market forever. There's plenty of producers around the world, off patents, cheap to produce, and it proved to decrease mortality, right? Which is the outcome we are looking at. Next, please. So when you're looking at the ability to deliver at scale, there are several what we call market interventions that will need to be pursued, from intellectual property, which is bound to be important. For example, we have monoclonal antibodies proving to be effective because they are expensive and they're hard to produce. Regulatory status, the complexity, maintenance costs, supply capacity, and conflicting needs, because some of these drugs are repurposed drugs. Right? Next. And then we also have a diagnostics partnership that's co-led by FIND and the Global Fund. And this partnership has 4 work streams: the supply, the low and middle income country testing capacity, R&D of tests and digital tools to support testing, in the market shaping. Next, please. And I don't need to tell this to this audience, right? But it's evident. This is taken from a presentation that we did for member states 2 weeks ago. Testing is essential at every stage of this pandemic. It's not just at the beginning to follow up patients. It's important at every stage of the pandemic. And they are essential to limit the spread of infection. And many countries have shown that in the absence of a good therapeutics, in the absence of a vaccine, the test, trace, and isolate works. So we do need a lot of investment in testing. Next. And barriers today means we cannot reach everyone who needs the test, right? And we rely on systems and infrastructure that are complex, expensive, slow, lab-based, and resource-intensive. We have supply shortages that jeopardize access, right? Manufacturing capacity is not in place to rapidly scale up production of tests to meet global demand. And we all know the RDTs need innovation, and I hope Rosanna will touch on this. We need faster, more accurate, affordable, easier to use tests. Next. And what is this work stream, this global partnership trying to deliver during the next 12 months? Well-performing antigen RDTs and point-of-care molecular tests developed. That non-proprietary test result readers app and interoperability solutions are developed. That we do have regionalized production, including in low and middle income countries, and a mechanism set to make RDTs affordable and available. Because it's the availability and the affordability are hugely important right now. We're aiming at having 500 million tests procured, and we are expecting to have country policies and uptake in integrated testing strategies driven in 50 more countries. So all countries should be able to deploy affordable and quality assured point of care tests. That a significant number of low and medium countries have been supported to put in place effective test, trace, and isolate strategies. And this, it doesn't start anywhere you don't have the diagnostic. And we want the disruption of core health services minimized. Next. Some of you may know, but some of you don't. So I brought this because this is a very peculiar, this is a work that only WHO does in terms of the pre-qualification work and the regulatory work. So the WHO emergency use assessment and listing mechanism was developed in response to the Ebola response. And it's a risk-based approach to expedite the availability of IVDs that are needed in a public health emergency situation like we are living through. And it's intended to assisting procurement agencies on the suitability in member states on the suitability for use of a specific IVD based on a minimum set of available quality, safety, and performance data. And it's time limited. Next. So what have we done so far? The ULL, it's also used for medicines, okay? So from the declaration of a public health emergency of international concern in January, we did an expression of, we issued an expression of interest for manufacturers of nucleic acid under the ULL procedure in late February. And in April, we extended the invitation to RDTs to antibody detection. In June, we moved to RDTs for antigen detection. And now in July, we have moved to immunoassays intended for antibody detection. So you can find this information on WHO website. You just look or you Google ULL and you find it. Next, please. And this is what we have so far, interest of manufacturers in the WHO on the NAT and antigen. You see that more than 90 manufacturers manifested interest. 65 have signed in the LOA, and 15 were listed and 6 were failed or terminated. For the serology, you have the different times, right? More than around 100 applicants, but 15 active applications only. And for antigen detections, the latest one, 9 manufacturers and no active application yet. Next is the last one, and I apologize if I stepped over a little bit on time. So I think the next steps is that we do have a cautious optimism because there's so much interest, there's so much negative impact of this pandemic everywhere. It practically destroyed historically well-performing health system in rich resource settings. Right? We have tragedies occurring where we never expected them to happen. Right? So it's extremely important that we do keep a cautious optimism, but that we collaborate across sharing knowledge, information, and also the technologies for us to be able to defeat this pandemic. And it only will only happen if everybody works together. So it's a pleasure to be here today and to be talking to all of you. Thank you very much.
Perfect. Dr. Mariângela, it was very, very interesting, the presentation. We have some subscribers here asking if you can share this presentation, if you can send to people that was registered in the event. Thank you so much. Now we're gonna pass the word and the floor to Dr. Rosanna Peeling, and I think she will be able to manage to share her own screen. Let me see if she has all the credentials already to do this. So, Dr. Rosanna, can you try sharing your screen and see if it's working?
Can you see it now?
Yes, I can see it.
Yeah, okay. So thank you very much for inviting me to share with you what we know and what we don't know about how to use diagnostics to support patient management and public health measures in the fight against COVID. So I'm going to start with just looking at patient management. Dr. Simão has showed us all the tests that have been I guess, manufactured for use for support patient management.
Dr. Rosanna, I just checked here, and actually I can see, but I think I was seeing my own, and people cannot see. Can you try one more time? Sorry about that. Sorry to interrupt.
Okay, sorry. Let me try sharing screen again. Okay, share, and then I go to my screen. Can you see now?
I can see. Can you see, Carlos?
Yes, it's perfect.
So
just go into presentation mode.
Okay.
Yeah.
Right. Okay.
Excellent.
Okay. So I'd like to start with diagnostics to support patient management. Dr. Simão has already shown us how many tests are available, especially the molecular tests. I think very early on in the epidemic, as soon as we knew the sequence of the virus, a lot of groups already were able to develop a molecular test to amplify the virus out of patient samples. So we have a huge number of lab-based assays, as well as starting to have some point-of-care molecular assays that could be done outside of lab settings. And so molecular tests detect RNA or DNA, and so for any viral infection, that is possible usually within the first week after onset of symptoms to be able to use molecular tests to confirm infection. But usually after the first week, after the period of viremia has passed, then no matter how sensitive your test is, you won't be able to detect virus from these patients because they could be no longer shedding virus or shedding a small amount of virus. But there are some exceptions to this rule, which I will talk about later. And then we also have antigen tests. Antigen test looks for viral proteins. And so they can also be used to confirm infection if they are very specific against a particular virus that you're looking for. And usually from our experience with other viral diseases of epidemic potential, such as dengue or Zika, we know that we could detect antigen in patient samples a little bit longer than we can detect DNA or RNA. And so there could be a longer window. Plus, there are point-of-care antigen tests that could be done outside of the lab, either on a machine or as disposable lateral flow dipstick type tests. And so these tests are available, and but the problem with antigen tests is that the sensitivity is not as high as a molecular test. And depending on what targets companies choose, the specificity may have a little bit of cross-reaction with other potential, say, coronaviruses or for dengue and Zika. We saw in the Zika outbreaks that some of these actually cross-react there's cross-reactivity between dengue and Zika. But the point-of-care antigen tests could be done in communities, and they could give results within 30 minutes. And they're less expensive than the molecular tests. And then we have the antibody detection test. And for COVID, because we're only now 7 months into the pandemic, our understanding of antibody response for COVID is still in its infancy, I would say. There's a lot that we still don't know. And I will go over some of the information that we know already, but traditionally, serology tests are used to detect antibodies that are produced as a result of infection. So it's a marker of exposure, a marker of infection, and it's useful for surveillance. And so on the whole, if you look at the 3 A's of accuracy, accessibility, which is ease of use, where it could be used, and also affordability. We have molecular tests that are highly sensitive and specific, but not very easy to scale, and also the most expensive option out of the 3. And then we have antigen detection tests that could be a second line of options, including the point-of-care tests that could be a lot more scalable at a lower cost than molecular tests. And then finally, for antibody tests, they are, as we saw with HIV rapid tests and other rapid tests, the ability to use a finger prick for these tests to be done anywhere means that it's very scalable and is not as costly as the other tests. But before we start to look at how to use the test, let's go through very briefly what we know about the infectivity of SARS-CoV-2 and detection of RNA. So usually we could detect what we know now is we could detect RNA in people several days before the onset of symptoms, which makes control of this infection a lot more complicated than other viral infections like dengue and Zika. And you could, a person could remain RNA positive for up to about 50 some days post onset of symptoms, especially in patients not showing signs of recovery. And the peak of viral RNA is usually around the first 5 days post onset of symptoms, and then decrease very slowly with rising antibody levels. But in spite of that, RNA clearance is not always correlated with rising antibody levels, and especially in those who are critically ill. And so right now, we're not sure when people have an RNA result, whether they're shedding live virus or not. And so that makes it very difficult to try to use antibody assays and molecular assays to know what to do about public health measures. We do have very small studies that show that usually these viruses are not, a patient is not shedding infectious virus after a week of onset of symptoms, but that their RNA tests could remain positive for 1 or 2 weeks after that. And so that remains to be seen as more studies come in. What do we know about the immune response to COVID? We know that usually the maturation of an immune response takes about 40 days, and seroconversion typically takes place within 3 weeks of the onset of symptoms. But for COVID-19, what we found in a couple of these studies that I'm showing here is that the mean time for seroconversion it comes a lot earlier than normal virus infections. We have, from these studies, an average of total antibody seroconversion from having a low titer to having a fourfold rise in titer around day 11 after onset of symptoms, and IgM day 12, IgG day 14. And what is unusual also, besides the fact that the immune response comes very early the other distinguishing feature is that IgM and IgG comes almost together. In some studies, some people develop very transient IgM response and then a very robust IgG response very early on. And in others, you could see from these graphs that they come very closely together. So it's no longer possible to use IgM by itself as a marker of recent infection, and then IgG as a marker of past infection. And you could see from a review of the literature about the seropositivity over time that was prepared by the health authorities in Ireland, you could see that, for example, for IgM seropositivity within the first 7 days after onset of symptoms, various studies show that anywhere between 10 to 70% of patients in their study have already started to have detectable IgM response. And for IgG, we could see that with the one outlier, which is in gray, you could see that on the whole, IgG seropositivity within the first week, it's already in between 30 to 60% of those patients. So it's a very unusual type of response that we could talk about how to utilize that later. Now, normally when we talk about having rising antibody responses, that means that the host is slowly getting rid of the virus, neutralizing the virus, and have antibodies as well as T-cell immunity come together to give the host protective immunity. We know now for COVID-19 that antibodies against the receptor binding domain of the spike protein and the nucleocapsid protein are correlated with neutralizing activity in the lab. And you could see from the studies that are shown here that people do produce antibodies, these antibody responses specifically against the receptor binding domain and the nucleocapsid domain very well within the first week and continuing into the second week after onset of symptoms. But does it mean that they're getting rid of the virus? So in this particular study, from Hong Kong, where they have a lot of experience and expertise with the first coronavirus outbreak, SARS-1 in Hong Kong. They studied the antibodies, both IgM and IgG, against the nucleocapsid protein and the receptor binding domain of the spike protein in both people with severe symptoms and also those who have mild infection. And you could see that people who have severe outcomes actually produce these neutralizing antibodies very early on and to very high levels compared to the mild cases. That those antibodies seem to come later, and perhaps some are not as high as those for the severe cases. And we know now that some studies are reporting that in some cases when people have very mild infection, in fact, they fail to produce detectable levels of antibody. And then as you look to the graph on the left, where the authors have actually looked at a virus from the saliva or from an endotracheal aspirate, over the same time that you see all these antibody responses, there's still, all these same patients still have a lot of virus. And so, so that's why we're uncertain whether having a neutralizing antibody response means that you are now no longer infective or shedding virus. So what is it unique that we could exploit in terms of what we know about COVID diagnosis? The fact that antibodies appear so early and that given that many parts of the world, many countries are unable to compete for the resources in terms of reagents for molecular testing, and in the early stages, we don't have antigen tests yet. Is it possible to use antibodies to supplement where you have a limited capacity to do RNA? So this one study showed that if you combine, in a patient set that they have, if you combine antibody assays with RNA assays in the same set of patients, you could actually improve the sensitivity of the diagnosis by 10% or more. And so they show that within the first week, 94 patients, if you detect, you could detect RNA in 67% of them. But if you add on the antibody response, which at that time is only about 38%, you could detect 78 or 79% of cases. And so the other reason for thinking about using antibody tests is that people typically present late, especially if they don't have shortness of breath, they only have fever and cough. They usually present late because they want to see whether it just goes away on its own. And so more people tend to present in the second week, by which time antibody assays would have quite a lot of use. And as shown here, in days 8 to 14 after onset of symptoms in 135 patients, the level of RNA positivity is only 54%, but if you use a very specific and sensitive antibody test, you could detect cases in 89% of these patients or 90% of these patients, for a total of 97% case identification. And so, so these are the kinds of things that we could think about exploring, but it really depends on having a very good, very specific antibody assay. And this is combination of antigen or antibody assays to try to identify cases is not new, it's not unique only to COVID. I give you at the bottom there a reference to how we look at dengue diagnostic algorithms using a single sample. If you combine DNA tests, molecular tests, plus antibody tests, or NS1 antigen tests plus antibody tests, you could diagnose 90% of the acute infections within the first 10 days of post-onset of fever using a single sample. And so that was done by the CDC dengue branch in San Juan, Puerto Rico. Now, innovative uses of serology where there are a shortage of molecular tests. Here, I give an example, and we've written up this as a part of a paper that's now published in Lancet Infectious Diseases. In Peru, for a population of 32 million people, there's limited molecular testing available in the early days of the pandemic, and only 500 ICU beds. So the government was very wise in very early on setting up a hotline and a website ran by the Ministry of Health to allow those who are symptomatic to not try to flood the healthcare system, but by calling up to or connecting on the internet to report that they have symptoms. And what happened was that during the call, the people who are severely sick or who are special at-risk populations, such as the elderly and those with comorbid conditions, are prioritized to be seen first. And what they did was to send teams of trained healthcare workers who could do a rapid serology test detecting IgM, IgG to the homes of these patients. And so if the patient who's symptomatic is positive and the symptoms are severe, then they're immediately admitted to hospital. Those who have mild symptoms, who are positive, who test positive, could isolate at home. But if they're not able to isolate at home, they're then taken to a government quarantine facility if the conditions of the home does not allow them to isolate. And then those who test negative would have a molecular test, a throat swab or a nasal swab taken for molecular testing. Now, before they started this, they were already 6,000, 7,000 tests behind in terms of molecular testing because there's a long queue waiting for only several facilities to do testing for the whole country. But with this rapid community-based triage of symptomatic individuals, they relieved the backlog and the waiting time for molecular testing, and they prevented the healthcare system from being overwhelmed. So it's a very good innovative use. But again, I stress that you have to make sure that the test is highly specific for COVID. Now, do we know enough about protective immunity to be able to discharge, recover cases from hospitals? Because hospital beds are usually in very short supply. And if there's a long queue for molecular testing, it's difficult for hospitals not to discharge patients if they have to have two negative molecular tests over several days in order to qualify to be discharged. And so, but because some patients can remain RNA positive, but despite rising levels of IgM, IgG, so we cannot use just the fact that they have antibody levels to use it as a criteria for discharge when RNA testing is not available. And so, so this is a problem that remains to be solved. If we know more later, this could change. The other aspect of using serology tests that's been talked about a lot is, can serology tests be used as immunity passports for allowing workers, especially critical workers such as healthcare workers, workers who work in care homes for the elderly, etc. Can we use serology tests as immunity passports for them to return to work after they had recovered clinically from COVID? But because we still don't know about protective immunity, and we know that in spite of having rising levels of neutralizing antibodies, some patients remain RNA positive, but we are not sure whether they're shedding live virus. So right now, we cannot use serology tests as immunity passports. Now, what about using diagnostics to support public health measures? This is now especially important because we really need to understand the true extent of the pandemic at this stage, 7 months into the start of it. But in many countries, changing testing strategies over time has made it very difficult for countries to estimate the actual proportion of the population that has been defined, has been infected. And yet this information is very crucial for developing evidence-based strategies to introduce or to ease public health measures and travel restrictions. And now that we know that as much as 44% of COVID-19 transmissions can occur when individuals are pre-symptomatic or asymptomatic, seroprevalence studies are the really only useful way of understanding the true extent of the pandemic. To be able to use it to monitor trends over time, to use it to map geographic distribution of the pandemic, identify hotspots and at-risk populations that would need special attention, and also to, over time, assess the effectiveness of different interventions. Now, I think that in terms of the use of diagnostics, it would be very nice if we could figure out a way while we're waiting for a vaccine to try and use diagnostics to monitor how we could make sure that the country has a healthy workforce for its hospitals and care homes to prevent deaths, especially in those who are especially at risk, like the elderly and the people with comorbid conditions. To have a means of monitoring safe environments in healthcare facilities, workplaces, and schools. And if we are going to allow mass gatherings, such as, return of church services, sports events, concerts, festivals, how are we going to monitor that these are safe places? And as Mariângela said, no one is safe until everyone is safe. Is there a role that we could use diagnostics to help with this? So let me just show you a slide that I took from, I borrowed from Professor David Heyman. And so this is about the debate about whether church gatherings should resume. This is in Washington, in the US, where there's a choir practice in a church. One person was positive for COVID, and in time they actually traced that 87% of this choir group actually developed COVID-19. And so we know now that there's a lot of droplets being emitted during singing. And so this is something that we need to be very cognizant of, and to be able to figure out how to resume these activities as we ease up travel restrictions and also mass gatherings. So to continue with what Professor Heyman had proposed, is that he urged us to think about translating the outbreaks into successful viral suppression, and to use diagnostics to help us with understanding how to do that. And so he proposed that we use a combination of antigen and antibody testing to shield the populations that are most at risk. So this will be in hospitals, in care homes, etc. And then patient detection, where there isn't a scalable point of care testing, molecular testing, perhaps use antigen as a way to supplement that, to have a rapid diagnosis so that public health measures in terms of isolation and social distancing can be implemented right away as soon as the diagnosis is confirmed. For contact tracing for isolates, for index cases, around index cases, and isolation of contacts for 14 days. And he proposed antigen testing, but we know from the experience in Singapore that they were able to use antibody testing to connect two clusters of cases in the early days of the pandemic in Singapore. And this is especially important after the exposure event has gone more than 7 days, to use antibody assays as well for contact tracing. Now, mitigation on understanding transmission patterns in mass gatherings. How can we use antigen tests and antibody testing to try to monitor these environments? And also in Asia now, especially in Singapore and in Hong Kong, they've adopted a way to do what they call a circuit breaker, and is to try to enforce physical distancing. As you ease restrictions, now and again, enforce it again, just to be able to break the transmission pattern, because as you ease restrictions, invariably a number of cases in the community would rise if there's a reservoir of virus in the community. But by inserting these circuit breakers, you would let it go for a while and then lock down again for a period, and then let it ease up again. And hopefully with that, every second wave or third wave, the number of cases would be smaller and maybe fewer clusters, and then gradually the the epidemic would go away. So that's how, with Professor David Heyman, he was proposing that we use these tests. Now, in terms of health worker surveillance, health workers are a really critical and valuable asset for us in the fight against a pandemic. We really need to make sure that they are safe and that they are not exposed to unnecessarily risks. And how do we monitor that? Now, there had been just published on July 23rd at Lancet Infectious Disease, a very detailed examination of how to monitor healthcare worker in a pandemic situation. And unfortunately, other than the fact that they said regular screening of healthcare workers by PCR is unlikely to be an effective means of workforce management, they didn't really go into a lot of specifics. So they end the article with saying that supporting healthcare workers in self-monitoring, and this includes self-monitoring of temperature as well as symptoms, and self-care, and then providing them with easy access to diagnostics and medical and psychosocial support, and offering clear guidance for safe and timely transition back to work will strengthen patient care as a whole and could ultimately improve outcomes. So it's vague. We may need to think about how to have more pragmatic recommendations for what countries can do about their health worker force. So in summary, I like to say that diagnostics play an important part in the COVID-19 pandemic response. We need to make sure that the right test is used on the right patient in the right place at the right time, and that we could have innovative ways to use antibody assays, which are easier to scale into communities than molecular or antigen tests. And until we have more sensitive enough antigen tests, we cannot use serology tests as a way to discharge patients from hospitals or as immunity passports for returning to work. But we can use serology tests for surveillance, and that we need to think about how to use diagnostics in general, all kinds of diagnostics, to try and inform how to ease restrictions and ensure that schools, workplaces, mass gatherings are safe. Thank you very much. And I'd like to thank all my colleagues at the school and discussions with Africa CDC, the colleagues at FIND, and especially to Amica Tenori at the Federal University of Rio de Janeiro for all these discussions that led to what I proposed here. Thank you very much.
Thank you, Dr. Rosanna. That was an amazing presentation, as well as the presentation made by Dr. Mariângela. I would like to pass the floor to Carlos Gouvêa, but before, I would like to say sorry to Álvaro Pulchinelli because I mispronounced his last name in the presentation of this webinar. I said Pulchinelli. Sorry about that, Álvaro. Thank you so much. Carlos, please, you can introduce the next panel.
Excellent. I would invite Álvaro to upload the presentation, while I really would like some thankful words for Rosanna and Dr. Mariângela. I think it was a great, we have been getting several messages here of the high level seminar we are conducting. People are really amazed and thankful for you both to share so important information and indications of a better future on how to go and to proceed. So now we are going to have the presentation by Álvaro Pulchinelli, who is the coordinator for the program of evaluation of coronavirus diagnostic tests that we are conducting. It's a really impressive program that it was possible thanks to the good idea of Rosanna. When I was at London School in March, mid-March, we discussed, okay, so many products should come to the market, how to evaluate. And Rosanna was structuring this kind of global assessment program, and Aladiv and Cbdl here in Latin America decided to really go for it. And so with very important partners like SBPC, SBAC, and Abramed, we were able to have a consortium of several key labs with access to important samples from different patients. Álvaro is going to go into detail, but it's important to say that we are involved in a kind of three-pillar project. The first one, access. And for access, thanks to Anvisa, we were able to have fast track for GMP and evaluation and registration of diagnostic kits. We have over almost 400 tests already registered in Brazil, and at least several others that are taking no more than 7 days to be evaluated and approved proper registration, which is great. It's really something. However, how to deal with this bunch of new products in the market without further information? Anvisa had the basic, but we need to joint efforts exactly in a kind of program for post-market surveillance. Then it's exactly what Álvaro is going to talk about with this special program. And finally, but not less important, is how to have a general approach to the market with innovative ideas. So this massive testing solutions, how we can do in a very responsible way. So besides the almost 6,000 hospitals in Brazil, over 16 to 18,000 labs, we have a potential of 88,000 pharmacies and drugstores. Thanks to Anvisa that reviewed the regulation, the pharmacies and drugstores in Brazil are also now allowed, within certain conditions, to perform diagnostic tests, basically rapid tests inter-premises. So it's another option. And finally, and also very important, companies can buy directly from importers or manufacturers diagnostic tests to perform for their own teams and employees, provided they are linked to a clinical lab, according to Brazilian regulation. So the clinical lab can support, execute, and give the final information for the worker or citizen in this condition. So we are little by little increasing the access to different opportunities, and especially considering the importance of information in a general database, now centralized in the Ministry of Health, and that could actually have a very good impact in terms of epidemiological studies. So Álvaro, please go ahead and have a good presentation.
Okay, thank you for inviting me to talk about some words about the role of the diagnostics in the fight against the pandemic COVID-19. So, and okay. The SARS-CoV infection, it's a variable types of diseases in the many forms of presentation. The transmission, it's person to person. Incubation, it's a range from 2 to 14 days. Main symptoms, it's very, very variable. Fever, respiratory symptoms, and gastrointestinal symptoms. In clinical presentation, science, asymptomatic infection or symptomatic disease until critical disease. And the clinical progression is variable to make cases several, shows several respiratory, but we have a very number of cases without any symptoms. Coronavirus, the structure is showed in this slide. It's a RNA virus, and we have to pay attention with the protein M and protein spike. And the ACE receptors are responsible for link the virus within the target cells. So the virus complete your circle, your your circle of disease, and we have unmet medical needs in this process. This paper shows that the variability of infected population. We have asymptomatic, mild, moderate, severe, and critical population affected. Who suffers more with COVID-19? Elderly people, diabetics people, hypertensive patients. In the world, 1.7 billion people are in the population risk. But most patients are asymptomatic, only 5% have a critically ill. Contacting with patients, we have 50% don't get sick. On the other side, 50% get sick. So this patient sick, 30% with respiratory symptoms, 70% without respiratory symptoms, but 70% over 60 years old. Asymptomatic patients have a great potential to transmit SARS-CoV-2. Asymptomatic patients can transmit the virus for periods longer than 14 days. The patients with mild and moderate symptoms and asymptomatic patients may be diagnosed with false negative results depending on the date of the test. It's a problem to find these patients. This paper talk about this false negative test for SARS-CoV-2, and the result, the conclusion is patients with false negative or asymptomatic results are very responsible for virus transmission. Symptomatic patients have problems too. The symptoms are similar to common cold symptoms, dyspnea and high fever. That define the main clinical difference between COVID-19, but are similar to other viral respiratory infections, variant virus respiratory, influenza A and B, and H1N1, and so on. The clinical manifestations, the principal are fever and dyspnea. Laboratory tests, we have three groups: the molecular tests or NAT tests, serology, only we find antibodies, and point-of-care tests. The gold standard is NAT tests. So the samples are taken from with a swab from nasopharyngeal or upper respiratory tract samples. It's considered highly specific, or the gold standard for diagnosis. The limitations, but the other side is because the sensitivity may vary. Maximum sensitivity occur between 18 to 14 days of symptoms onset. The regions are displayed in this slide. Depending on the day, the material collection in relation of or to the onset of symptoms. Maximum sensitivity occurs between 8 to 14 days of symptoms onset. Variation of RNA viral sequences. We have diverse genetic and rapid evolution of new coronavirus, and we have many protocols to find this. And depending the pre-analytical aspects, proper sampling and transport technique. The situations which the PCR-RT are limited, to detect the patients with COVID-19. 1, symptomatic patients for flu syndrome or severe acute respiratory syndrome, more than 14 days. Patients with previous contact with an affected patient for COVID-19, possibly of false negative results or with RT-PCR. And in Brazil, we have a specific situation, shortage of reagents and laboratories using molecular biology techniques. So this problem is added to the problems who I said ago. Antibodies to COVID-19. Antibodies are generated against the protein spike and the nucleocapsid. The antibodies appears mainly at the same time, but IgG may increase earlier than IgM. Until the 2020 year, we teach to our in the Escola Paulista of Medicine, the infection diseases, first antibodies class IgM, after antibodies IgG class. In COVID-19, we have another situation. The virus don't follow the box. So, and the antibody levels are not directly correlated with clinical severity. How important is the diagnosis after the first week? In 2 situations, late the diagnosis or contact with infected patients. And aid the diagnosis of and management of conditions caused by COVID-19, like in patients with pulmonary embolism or thromboembolism, and patients with unusual dermatological presentations, or different diagnoses of other respiratory tract infections. So another situation is Kawasaki-like syndrome in children. So this paper concluded that serologic tests may complement the diagnosis with patients with more than 7 days of symptoms who had negative results or RT-CRP. The point of care, it's show like this device, and they use commonly the immunoassay by immunochromatographic method. Well, the general aspects of pandemic of COVID-19 have 3 axes. The first axis epidemiological, linked to prevention vaccines. The second axis, it's a treatment, like the cure or medicines. But the pivotal axis is the diagnostics to find of cases who will be direct the patients who take vaccines, who take medicines, cure, or who need more prevention. So the 4 institutions of Brazil, SBPC, Cbdl, Abramed, and SBAC, makes a program evaluation of coronavirus kits, diagnostic kits. This program starts intend evaluation of point-of-care tests based on one lab in a partnership with SBPC, Brazilian Society of Clinical Pathology, and Brazilian Chamber of Laboratorial Diagnosis. On week before, 1 week later, we have 4 labs to test point-of-care tests. The work of Carlos Gouvêa in joining forces with SBAC, Sociedade Brasileira de Análises Clínicas, Clinical Analysis of Society Brazilian of Clinical Analysis, and Brazilian Association of Medicine and Diagnosis. So we evolution to assessment for all technologies, so serology, point of care, and NAT tests and antibody tests. And now we have a portal with we link all the information about this program. How to respond to diagnostic challenge? Because we join the sector entities. We wrap in large laboratories. The major laboratories in Brazil are contribute to this program. The supply involvement, the work basically in the brilliant made for by the Carlos Gouvêa, and scientific knowledge and contribution of university too. So we have a protocol to analyze these kits, common to all participants, kits and laboratories. We have two arms to analyze these results. The first arm is a performance analysis. The second arm is reproducibility analysis. In the first arm, we have these points: sensitive, specificity, predictive value, likelihood ratio, diagnostic probability ratio. And the reproducibility analysis, we have the analysis intra-tests and inter-tests. So how this schedule? At minimum 100 tests analyzed by performance and reproducibility. So we have in the performance 3 groups: 7 to 14 days symptoms, 20 tests, 15, 21 days, more 21 days. In total, 60 tests. In other hand, the day 1, we have inter assay. So we need to 12 tests. So commonly use 3 results from these groups, totally 90 tests. And day 2, and then 3, 12 tests, 2. Total 33 tests. Completely 93 tests, and we have 7 reserve tests. So the program needs minimum 100 tests, but it's very common we have 100, 200, 300 or more tests are made in our laboratories. This is a program performance. It's a brief from results. We tested the serology, serology and RT-PCR. So we have show the results about it. In case of serology, after 21 days of symptoms, it's a better results. RT-PCR, we have a good results too. Look, it's this our website. Some numbers we have. We are 12 labs, private and public, 25 suppliers, more than 25 tests evaluated, over 6.5 thousand samples analyzed until the 23rd July. So it's in a few words what I would like to show our program. And excuse me for my macaronic English, my bad English. And I will now I will help. I need help from Carlos Gouvêa. Thank you,
Álvaro, thanks a lot. It has been a fantastic project. As he said, we have over 12 different labs, public and private, in different parts of Brazil, from Fortaleza to Paraná, Espírito Santo, São Paulo, Minas, Distrito Federal. And it has been great to count on their support. It's important to remark that this program aims to evaluate any and every kit that is in the Brazilian market. It's voluntary, so we invite companies to present the samples, and it's free of charge. So the labs are not charging anything for their service, for their time and dedication. And the idea is really to create a big database that we can share with for scientific purpose with different publications, not only here in Brazil, but with this joint effort with London School of Hygiene and Tropical Medicine and the IDC, the International Diagnostic Center. So we can really know not only what is the performance, how are kids improving, and give a kind of reference for the public and private market exactly to make the right choice, the right test for the right moment in the right environment and for the right person. This combination of different tools is what is really going to let us out of this crisis. So I would like to conclude this part and exchange and switch the floor to Felipe if he wants to make comments before we start the discussion. But it's important to remark that we have over 250 people watching this video that is going to be available later on, with people from all different continents. It's not only Brazil, it's actually, Felipe is in Colombia, Rosanna is in Winnipeg in Canada, Mariângela in Geneva, and Álvaro and myself in São Paulo, but we have people from Latin America, US, France, Korea, Japan, and thanks for everyone who is watching here.
Perfect,
Felipe?
Carlos. Thank you for the presentation, Álvaro, Carlos. I would like to start the roundtable just opening to some comments from Claudio Henriquez, Wilson, and Barcelos, and then really short, if it's possible. Let me see if they are here already. I think so. And if we can all open our cameras so we can have it, and then we should pass for a final regards for Mariângela and Rosanna if they can talk really quick at the end so we can close the event. So I would say more 25 minutes or maybe 30 more minutes so we can end the discussion. Thank you so much for being here. And maybe we can start with, I don't know, you would like to decide, Carlos, the order of the speakers. So if you can have like short comments, so because we already passed time. Thank you so much for all of you to being here and to support this program.
No, thanks everyone. I know we have been going a little bit further than we should in terms of time. Several colleagues couldn't stay longer, and I apologize for them, but I appreciate the involvement of everyone from Abrapharma, SBPC, even Cbdl. We have more people, but we have three big stars here. Claudio Maerovic, who is the three of them are good friends. So I'm really enjoy having to spend time and learning a lot with them. So we have Claudio Maerovic that has a very long and fruitful career in the health sector. Some of the positions were in Anvisa, Ministry of Health. Currently he's at Fiocruz. Wilson Skonik currently is the president of Abramed, but has also worked quite hard in the different areas in the clinical lab area at especially SBPC. He was the last president before Carlos Ferreira. And Barcelos, who is a devoted person for the support and fighting always for the improvement of conditions in the clinical lab area. Also, he's the president of ISBAC. So please, Claudio, if you want to start, then Barcelos and Wilson, and then we go for Rosanna and Mariângela to answer. If anyone wants to say in Portuguese, please feel free and I can translate. So, Claudio?
I'd like to begin in English. So, first of all, I want to congratulate Carlos and Felipe for this meeting and also for the program to evaluate tests available in Brazil. We're living a very unusual situation. In Brazil, besides our lack of leadership, lack of plan to control epidemics, we're living in a lot of problems. I'm talking from the view of health surveillance system. When you look at diagnosis, when we talk to doctors, most of them feel very unsafe, with lots of doubt when they look of results of laboratory tests, especially if we're talking about serological tests. I've been trying this experience myself with people that asked me for testing, for interpreting testing. As we look at these nowadays, I think we've been living a huge mess when you talk about testing in Brazil. We live the lack of molecular tests from the view of health surveillance. We could say the molecular test is the unique, useful test for the activity, the day-to-day activity. The immunologic tests certainly are useful for monitoring what's happening in different places, for generating data about different groups, different communities, but not for performing day-to-day activity of health surveillance. And it's been very hard so when people of the teams, different teams, city, state teams of health surveillance try to perform test, trace, and isolate cases without the availability of molecular tests. When they use point of care, rapid tests, or immunologic tests, it looks that they become more lost than when they get uniquely the clinical approach. So I have this first question. I think we should be having versions mostly to make it available, some kind of trustable tests to make the early diagnosis. And I think we've been talking a lot about RT-PCR, but maybe there are some alternatives like the RT-LAMP or the antigen tests or any other alternative that could bring a tool to the team that is in the field to identify positive cases, isolate and trace contacts, isolate. That's the only way we have to bring the collaboration, to bring some results to the work of these teams. Otherwise, we should not have these teams. It's we're throwing money away. Having these people in territories trying to gather information, trying to track people, trying to give information to people, because they can't isolate, they can't identify and isolate who's spreading the virus. I'd like to recall one article from 1 month ago. It was published from in the Royal Society of Open Science by Julian Piro. And when he talks about a proposal for universal screening with PCR in England every week. I imagine Rosanna has seen this paper, and he calculates a cost of about £1 billion per month to perform this, and compares the meaning of spending this money with tests with the meaning of spending the money the way it's being spent nowadays without results. I think it's a reference for us to think about. How could we multiply the offer of tests to really perform some new proposals of controlling the pandemic with huge testing and with big numbers, and looking with a focus, really a real focus, no, not what we've been doing today, on test, tracing, isolating. I'd like also to bring another question. It's about the. I'm fond of the program you're developing. We've been talking a lot about this, but I'd like to think with you about the next step. You're building good information, useful information, but when we look at what's happening in laboratories, what's happening in the health services and survey services, people don't know what's happening. People don't know the characteristics of the tests. Mm-hmm. People have the results and make some efforts to interpret. Anvisa is not able to use these as a screening to bring the tests to the market or not. We should have some agreement between the work you've been performing and regulatory authorities or specialty associations from physicians of different specialties to make this useful. I think it's we now have the risk to have this rich information not being used for people, for the specialists, for the professionals who should look at this and take this as a really valuable, precious information for their work. I think this is the tips I'd like to see discussed. Thank you for being here. Very nice to see here Mariângela, good friend, old friend.
Excellent. I think it's better really to complete the questions or observations, remarks by the three, and then we give the floor to Mariângela and Rosanna. Barcelos, se quiser aproveitar, o Barcelos teve problema na conexão e voltou, só que acho que caiu de novo. He's having problems with the internet. So Wilson, if you want to go ahead, please.
Thank you, Carlos. Thank you for this invitation. Congratulations for Cbdl and to Felipe from Jata for organizing this webinar, and congratulations on the presentations made. We know that Brazilian labs have developed alternative methods to mitigate the lack of access to molecular tests. Genomic platforms were adapted and mass spectrometry are being used. And I would like to know from Rosanna and from Mariângela, how are other countries evaluating such initiative? And another question is about our current situation in Brazil. Now there is a discussion about the incorporation of serological tests in the health system and who should pay for that test. If the private system should reimburse this test or the public system? Do you know what happens about this situation in other countries? That's all. Thank you.
Rosanna and Mariângela. Rosanna, would you like to start?
Thank you for those comments. I will first address Claudio's comments and questions. There's no doubt we really, for test, contact, tracing, and isolation to work well, we need to have a very timely diagnosis, very early and timely diagnosis, right? If you have a molecular testing queue of several thousand, and you can only get the results after 1 or 2 weeks, then already the confirmed case could have infected a lot of people already. And so I think that, but there's no real good solution right now. The very, very sensitive and specific tests are not scalable. Even the point of care molecular tests, we are constrained by 2 factors. One is that the point of care machines for molecular testing are very highly precision machines and very difficult to fabricate on a large scale. The fabrication is it takes time. And even if you do have the machine because of HIV programs, TB programs that have already bought the, say, GeneXpert platform, etc., the cartridge itself is $20 US each. And so that's already quite a bit of money if you think about, that compared to a lateral flow assay that could be just a few dollars. But I think what we need to do is to figure out for the trade-off between the 3 A's, the accuracy, the affordability, and the access, and come up with a mixture or a good strategic mix of different tests that you could use in different settings to get the best results possible. And so even though we know serology tests are not used normally to confirm infection, having a very specific serology test and that you could give the result in 15 minutes and it's IgM, IgG positive, then you already have some suggestion that this could be a case. And you could, it's better in a pandemic situation to err on the side of being more conservative, more cautious. And even if you overdiagnose a case, you are only helping to stop the infection spread. So that's one thing. The other thing is that you're absolutely right that we are collecting a lot of information, but it's based on how good the characterization of the test is. So if you actually use a very bad performing test and you get all this information, which may be, misguiding you, then it's better not have that information than to have, if you have a test that's highly not very specific. And so when you do a sero survey in a prevalence of about 1%, you're getting 2 false positive for every true positive that you have, even if you have a specificity of 98%, right? And so these kind of equations need to be figured out in order to try and properly interpret the results that you have. And that requires everybody working together. WHO has already convened a group, and I'm included in the group, to look at the target product profile of what are optimal sensitivity and specificity for each type of test and what are minimal requirements. And so that gives some guidance as to what is acceptable for use in these studies. And then I'd like to address Wilson's comments about what other countries are doing a lot of work on genomics, trying to understand whether the virus has mutated. We need to know in case that in the mutations will bring about increased infectivity, and that's been a rumor that's been circulating for a long time, whether having the mutation would allow the current tests that we have, molecular tests that we have, not to work anymore because of the mutation. Now, one thing that's in our favor is that these coronaviruses, unlike a lot of other viruses, have a proofreading mechanism. So mutations are much less likely with coronaviruses than other viruses because of this proofreading mechanism for the replication. So, but there's been over 1,000 genomes deposited into a public database, and people are tracking to see whether, you know, there's been sizable mutations. And then the whole issue of who should pay. I think in a pandemic situation, if you rely on people's ability to pay or willingness to pay, then we've lost the ability to control, because we need everyone to do their part. So as much as possible, it has to be a public system that pays for this. Over. Thank you.
Mariângela, if you want to make your comment.
First, let me say it's a pleasure to see Claudia. It's unexpected pleasure. For those who don't know, I worked 30 years in the Brazilian health system, and that's where I met Rosanna when I was in the Ministry of Health in Brazil. So, and Claudia and I are friends of many battles, right, Claudia? Survivors, let's say. I think a few things I'd like to say. First, we are, I heard someone say the other day from Wellcome Trust that this is not a 100 meters run. We are running a marathon. This is not going to go away anytime soon, although we would like it to go away. Right? So we need to put in place, there are things that are emergency measures, and there are things that need to be put in place for the long run, right, for us. And I think I would like to congratulate the initiative that Álvaro Pulchinelli presented. It's good that the countries are getting organized, and it's good that Brazil is setting the pace on that, in spite of all the other problems. The second thing I wanted to address was the question that Dr. Koenig, Wilson, it's easier, raised on the ability to pay and what should the private sector pay. What is important, I think, complementing what Rosanna said right now, it's that patients don't have to pay, right? That they don't have to take money out of their pockets. Then the way that the health system is structured, I know from my previous life, because I've been a Brazilian my entire life and only 10 years in the UN, I think it's very fair that in Brazil the health system pays, and that the ANS people are paying for private insurance, that the private insurance also pays. And I'd like to cite in the other countries what's happening. We have different types of systems, right? Mixed systems and universal health coverage systems, where the government pays for everything, right? This welfare states and so on. And private insurance systems like the one I live in, the country I live in now, it's Switzerland, right? Which is all private insurance, private health insurance. And addressing what Claudia was saying about the difficulties and the difficulties in access and you know, this country is one of the, Switzerland, which is one of the richest countries in the world, had a huge problem to access diagnostics during the pandemic period here, during the hard time. It was extremely difficult. They were only testing severe cases because there was an issue of availability of tests. So even in resource-rich contexts, there were problems. Why wouldn't this problem be repeated in the developing world? I'm not putting any excuses there, but I'm saying These are expected problems. And what we've been seeing, I think a lot of the different things that have been going on, a country should look at what happened in other countries, what type of response, and that's partially what I've always been saying about Brazil and the current situation, the epidemiological context and the Brazilian response. You need to be looking at what other countries did right, and those who did wrong, what went wrong. There's enough now, because this pandemic now it's 7 months old. So there's a lot of accumulated experience. But going back to the delay in the early phases and the availability, even in research-rich settings, in Switzerland, I experienced twice, as a person, because in April I had a flu, and then I had to be tested, right? And then I had to go to a private system, not the government set system. But even the government set system, you would have to pay, your insurance would pay for your exam. Now, just before I was about to travel to Brazil for a family reason in June, and I had a cold, and they freaked out. I had a simple cold. I was coughing, and I had some nose discharge, and they freaked out, and they sent me to hospital immediately to get tested. And now the test was free, and there were no lines. Right, I went there, and I went in and out in 10 minutes. I got the results 12 hours after, and it was free of charge now. So it's the dynamics vary so much depending on the stage the pandemic is, and depending on the ability of the health system to manage the cases. But lastly, let me say, Carlos, I think this pandemic has just exacerbated the inequalities. It's the ugly face of inequalities that we're seeing. You see what's happening in rich countries, and you see what happened in rich countries with welfare states, with a lot of social protection. You see the differences, for example, in mortality rates in the UK. The UK, they measure everything, right? Everything you can find it. So they measure the difference. Because in the US, you expect that because of the way the system works. You expect these inequalities to be shown. But you see the fatality rate in UK and other rich countries that affect minority populations or ethnic groups more. It was higher. The impact was higher among those that are more disadvantaged in society. And I think this is the opportunity we have through the health system and through this global solidarity, through making these tools available and setting for the long run to ensure that there is equitable access to the tools that are developed, that are proven to be safe and effective, and that we have the entire range from the diagnostic to the treatment and eventually to a good vaccine that will help us to get over this somehow. Thank you very much.
Perfect. Thank you, Mariângela. Thank you, Rosanna. We received a question from our YouTube audience from Monica Duarte. She would like to know the impression of anyone who would like to comment about the perspectives of regulations of in vitro diagnosis. And I don't know if Carlos would like to say some things and maybe start commenting, and then we can start our final regards. Thank you so much for being here, for all of you. And please, Carlos.
Yes, thank you, Felipe. This is an excellent question. What we see is that today is already different from yesterday, and tomorrow is going to be nobody knows. But for the diagnostic area, I would say we have never been so much exposed, and in the good sense. Many people with wrong concepts, many people with no knowledge at all. Everyone became an expert on diagnostic tests. And you see on TV, everyone saying something and saying, no, that's not exactly correct. But that's the opportunity. That's the opportunity to explain, to show the value of diagnostics, to show that an early and precise diagnostics will make the difference for reaching the right therapy. It shows that 80% of the correct therapies are based and depending on diagnostics, so doctors really need it. And that's the value. And it's really to change and transform with a very minor expense. The overload of diagnostics is nothing if you are taking wrong drugs, wrong therapies. So if you can anticipate the knowledge of what has to be done, the much better it will be from a private situation with a citizen or from a public policy, healthcare policy perspective. So it's going to change. Brazil is showing that we have taken this first step, and everyone that follows Anvisa knows what Claudio started to do some time ago. Several other directors kept on moving and changing. And nowadays we see, for instance, 385 registrations for coronavirus already approved out of almost 500 and over that were evaluated. So 385 registered, 100 that were denied because the dossier couldn't comply with the basic. And now only 7 days for any new product, new technology that wants to come into the country will be evaluated, and there's going to be a decision. With that, we have so far a large number of tests made and new technologies, as Claudio and Wilson mentioned, and Alvaro also showed a little bit in the presentation. We have not only rapid tests and not only PCR. We have fluorimetry, we have chemoluminescence, we have LAMP, we have tandem mass being used for coronavirus detection. So many different tests and technologies, but also, and that's what Wilson showed, is even labs are looking for alternative solutions. They are inside their own base, they are developing new processes to use old technologies with new approaches, which is fantastic. Mariângela, you pointed out several key informations, and I like it very much. Someone asked, what is the next step? I think Claudio. I think there is no solution. Everyone has to engage in searching this solution. We cannot blame only the Ministry of Health for doing or not doing anything. We as civil society have to take this step ahead and also try to do something else, is what, for instance, in this discussion we are showing. It's the medical societies, the lab societies, the industry, academy, and organizations like WHO, PAHO, and several others. And one example is what, for instance, University of Pelotas has done. They started a small project that was aiming just for the Gaúcho population, just the people of Rio Grande do Sul. But at the end, it increased it, and it's a very nice program called EPI-COVID-19. They have so far screened 89,397 people in 130 cities. The protocol for this was based in 3 different waves. Each wave was around 30,000 people that would be screened according to, but just urban centers. So they had this first picture of what is happening in Brazil, showing the concentration of the disease, of infection. And okay, as a general rule, we have the first phase was 1.9% of prevalence, 3.1 in the second, a little bit less than 4% of prevalence in the third wave. But that's general. But if you see in the north region, for instance, you had a huge concentration of infection, as we know in Amazon, in Manaus, for instance. So that's another good example. They had done 3 phases, a huge number of collections, rich information, and now they are stopped for the 4th phase. They're needing funding to go ahead. The ministry supported and funded the 3 phases, and now what? They couldn't go on, but we have to look for solutions. Again, civil society, institutions, eventually WHO can also support this kind of initiative. And so many other things that really can do. If we see, for instance, the pharmacies, we were afraid, okay, the pharmacies are going to be able to perform. rapid tests, yes, they're doing a very, very good job. They have to follow several guidelines, very strict, and it's a very good pilot to know exactly what is the role of point of care. So far, Abrapharma institutions, Renato Porto was going to be here, he couldn't make it. We have over 1.6 thousand pharmacists taking part in this project. They have tested so far 371,000 people. Prevalence for this group is 14.4%. Okay, people who have already a suspicion, so just a serological rapid tests. So we have several initiatives that combined can really play a very important role. And again, industry is very interested in improving their products, launching each time newer solutions, and they are working very closely with us in this program of evaluation, because the results that come, that Álvaro was showing, are not only for the procurers, for the labs, public or private, but also for the industries themselves to improve the quality in the next batch or in the next development. So it's a kind of eternal cycle. So again, from my side, I would really appreciate very much everyone that has taken their time to watch, to participate, to contribute. I'd like to know Álvaro and everyone else for the final words, but from myself, it's really great. Mariângela, count on us. Cbdl, ALADIV, which is the Latin America Alliance for Development of In Vitro Diagnostic, is part of IDC of Rosanna. We're working very much together. Rosanna is probably traveling more to Brazil than to Canada during a normal period of time. But anyway, thanks a lot, and really count on us for this. And I would open for the final remarks of who else wants to say. Álvaro, if you want to say some words.
Okay. Oh, thank you again for inviting me. Dr. Rosanna, your presentation was amazing. If I have see your presentation 1 week before, many problems are solved to us, because we have a big fight with against the ANS, the agents the Agência of Supplementar Medicine. No? Dr. Mariângela, your presentation is very, very amazing too. Dr. Claudio, I agree with you say. The next steps of our program are very clear. The first step is make a consolidated data with our results. The second step after this is prove the clinical value. Clinical value is spend time, and spend money, and spend other questions. But these objectives are very clear to us. You know? And Dr. Wilson, thank you for watching us. It's all. Thank you again to Carlos Gouvêa for the organization of this meet.
Perfect. Mariângela or Rosanna, would you like to add some points?
Mariângela.
No, I think I already made I apologize because I made my final remarks before.
Yeah, I really like to thank everyone for inviting me to be part of this, and there's a lot of work to do, and what you're doing in Brazil, it's amazing. Apart from the political leadership, but I think technically there's a lot of really good expertise, and I especially congratulate Anvisa for being so quick to be able to approve these tests for use in the country. That's pretty amazing, and I wish other countries could learn from that. Thank you very much.
Thank you all. I think we arrived at the end of this webinar. Thank you, Carlos, Claudio, Álvaro, Wilson, Rosanna, and Mariângela for being here. I learned a lot with these presentations, and I hope we can have this kind of discussions again. Thank you so much, and See you soon.
Okay, bye-bye.
Bye-bye. Thank you.